Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
In considering the contours of the surface of the facial skeleton, we'll divide it up into basically the areas that make up the facial skeleton. We've talked earlier about the orbit, and we'll begin with the orbit in looking at the specific features of its surfaces. Deep within the orbit are a series of foramina and fissures, which will transmit nerves going to the orbit and to the periorbital facial region. If we look deep within the orbit, we can see the superior orbital fissure now this is passing up in this direction, and above the superior orbital fissure and medially placed, we can see the optic canal, which will transmit the optic nerve into the orbital area. Perhaps it's more easily looked at if we orient the skull in a fashion in which we can look into the entire orbit and see another feature, that being the inferior orbital fissure. The superior orbital fissure, which we can see in this region, will transmit then the third, fourth, and sixth cranial nerves into the orbital region. It will also transmit a portion of the fifth or trigeminal nerve, that being the ophthalmic division. The inferior orbital fissure leads immediately to the infraorbital canal. The infraorbital canal being that portion which is located from the floor of the orbit and opens by the infraorbital fissure, or intraorbital foramen, in this region. The groove of the infraorbital region is open to the orbit and can be distinguished from the canal by this opening. The groove will transmit then the infraorbital nerve and other accompanying vessels. Another feature of the orbit is an opening which can be located at its medial aspect, a very prominent opening, and perhaps you can see it best when I orient the skull in this fashion. You can see two of them on either side, and these are then the openings for the nasolacrimal ducts. On the medial wall of the orbit, there are basically two foramina. These two foramina are the anterior and posterior ethmoidal foramina, and can be located in this position. The anterior one can be seen here, and if we look deeply within the orbit, the posterior ethmoidal foramen, the posterior and then the anterior ethmoidal foramen. These will transmit branches of the nasociliary nerve, the posterior and anterior ethmoidal branches, and their accompanying vessels. On the lateral aspect of the orbit, there are one or possibly two foramina, depending on the individual. The two which can be shown in this case are going to transmit branches of the maxillary nerve to the lateral aspect of the face. Let me see if I can orient this in a position so that you can see it more clearly. Here, for example, is the zygomatical orbital foramen. The zygomatical orbital foramen, as I mentioned, may be single or double. If it is single, it is more nearly located in this region, and it will transmit the two branches of the zygomatic branch of the facial nerve, or of the maxillary nerve. They will appear on the face as the zygomatical facial branch through the zygomatical facial foramen. And if we look behind the zygomatic strut of the frontal bone and into an area in this region, one can find a zygomatical temporal foramen, which will transmit the zygomatical temporal branch of the facial nerve into this region, or excuse me, of the maxillary nerve. These basically make up the features of the bony orbit. The features of the maxilla are extremely important in orientation in dentistry because of the scanty amount of tissue that covers them. They can be palpated very easily. In the region of the nasal orifice, we have the anterior nasal spine, an anterior projection from the midline, a region which is basically pear-shaped, the piriform recess, and then the canine eminence, which can be shown to be this rise of bone, or eminence of bone, over the canine or cuspid tooth. Lateral to it is an area we call the canine fossa. The canine fossa is the approach to the maxillary sinus and can be used in the various surgical approaches to this region. A prominent feature of the anterior surface of the maxilla is the infraorbital canal, which opens in a downward direction toward the cuspid tooth. Laterally, the maxilla, as it passes into its infratemporal region, we have a surface of the maxilla which adjoins an area of the skull known as the infratemporal fossa. The infratemporal fossa is bounded by the infratemporal crest and the lateral pterygoid plate. That part of the maxilla which adjoins this fossa, then, is the infratemporal aspect of the maxilla. Within the infratemporal aspect of the maxilla, we can see, or on the infratemporal aspect of the maxilla, we can see foramina which will transmit the posterior superior alveolar nerves, and they can be shown one of such foramen at this point. They will also transmit the accompanying arteries and veins. Inferior to this infratemporal region is a portion which is called the tuberosity of the maxilla, and we can see this is the tuberosity then of the maxilla. In an individual in which the third molar is unerupted or missing, the tuberosity is more notable. An important feature of this lateral view of the facial bones is a strut which appears on the maxilla at this point. This is the zygomatic strut of the maxilla. Combined with the zygomatic bone, it forms the base of the zygomatic arch. An arcade, then, that is made up of the zygomatic strut of the maxilla, the zygoma, and the zygomatic process of the temporal bone. We can see that it also projects superiorly to attach to the frontal bone in this region. These are basically the features of the external or anterior surface of the skull, anterior and lateral. If we turn the skull and look at the perioral osteology, we will notice that the maxilla projects in this region, forms the hard palate when added in combination with the palatine bone, which we viewed earlier. Anteriorly, behind the maxillary incisor teeth, is located the nasopalatine or incisive foramen for transmission of the nasopalatine nerve and the septal artery and vein. As one passes to the posterior portion of the palate, we can see two prominent foramina. The greater palatine foramen. We can see them on both sides here, and located at this point is the lesser palatine foramen. The greater palatine foramen transmits then the nerve and arteries to the hard palate region, while those of the lesser palatine foramen will supply the soft tissue of the soft palate. And here you see an example of its counterpart on the opposite side. Again, one can see the tuberosity portion of the maxilla in this area behind the third molar of the maxilla. Other features of the inferior aspect of the facial bones will be discussed with the base of the skull aspects. One feature, however, that does project into the oral region and should be noted at this time is the hamular process of the sphenoid bone, and it is actually a projection of the medial pterygoid plate. This would be the hamular process. These have been then the basic contours of the midface. Now we do have, of course, another prominent bone of the facial region, the mandible. The mandible is made up basically of the base of the mandible, this portion, or body, the ramus of the mandible, and of these parts we can then see that alveolar bone is that bone which supports the teeth and is located above the basal bone in the body of the mandible. The coronoid process, a portion of the ramus of the mandible, and the condylar process and condyle of the mandible. Laterally, some of the features of the mandible can be seen quite easily. The mandibular notch, or sigmoid notch, is located in this region. Passing down the posterior aspect of the ramus, we are led to the angle of the mandible. This area provides attachment for the masseter muscle, and therefore an area or a notch which appears in this region, the pre-mesenteric notch, will transmit the facial artery and vein as it approaches the face. This is the pre-mesenteric notch. Another prominent feature of the lateral aspect of the mandible is the mental foramen, and can be located here, transmitting the mental branch of the inferior alveolar nerve. As we approach the anterior view of the mandible, we can see a prominent triangular region. This is quite prominent in males and less so in females. the mental trigon. The symphysis of the mandible is long since fused and obliterated in the midline. These have been the external features of the mandible. Now let's turn and look at the lateral interior view of the mandible. Again, we can see in this region the projections which we saw in the lateral view, the coronoid process, condyle, and leading down from the condyle, we can see what we call the endocondyloid crest. Another feature of the ramus is a crest which passes down toward the retromolar region, and this is called the endocoronoid crest, which will lead to the temporal crest. Clinically, we refer to this as the internal oblique line, as contrasted to the external oblique line, which if we orient our mandible in this fashion, we can see. The external oblique line passes down in this region. The internal we can see here, as I say, anatomically made up of two ridges. The endocoronoid crest leading into the temporal crest. Deep to this crest, we see the lingula of the mandible, and beneath it, the inferior alveolar nerve passes into the mandibular foramen. Again, we can see the muscular mottling associated with the attachment of the medial pterygoid, a counterpart to the muscular mottling we saw laterally for the masseter. Here on the body of the mandible, we can see a line which passes obliquely across the body of the mandible to the symphyseal region, and this line is the mylohyoid line. It is the attachment of the mylohyoid muscle. Leading from the mandibular foramen, one will frequently find a groove, the groove for the mylohyoid nerve, which will be supplying this muscle that attaches at the mylohyoid ridge. The mylohyoid ridge divides this medial aspect of the mandible into two fossae, one inferior to it for the submandibular gland, and one superior to it for the sublingual gland. An interesting aspect of this medial portion of the mandible is the fact that the lingual tuberosity, which is located above the mylohyoid line and supports the mandibular third molar, can frequently be seen to be rather thin. And in fact, in this particular specimen, one can see the distal root of the mandibular third molar projecting into the submandibular fossa. Surgery of this region could be complicated by the fact that this root could very easily be reflected into the submandibular fossa, a region which is actually outside the perioral area. At the very midline of the mandible, we can see the genial tubercles. These are attachments, points for muscles of the base of the tongue. And if we orient the mandible to look at its inferior aspect, we can see two fossae for the attachment of the anterior digastric muscle. In the inferior view of the mandible, we're drawn to the point that the mandible has really two arches. One which is represented by the base of the mandible, and another which is the dental arch. And the two are not superimposed on each other. An example being this lingual tuberosity, and it results in this close approximation of the third molars to the lingual aspect of the mandibular bone. It is also important, if you look at this from above, in a consideration of the retromolar region. Here we can see our internal oblique line, and notice that it flares out laterally from the arch of the mandible, so that any incisions in this area, it must be kept in mind that they should be made with the bony landmark of the internal oblique line kept in mind. If one is to pass directly back of the mandibular arch, one passes quickly into soft tissue, and in this region, the lingual nerve. This basically completes the contours of the facial skeleton, with the exception of one final area, and that is the attachment of an important raphe which passes into the retromolar trigon area. The retromolar trigon is very hard to show on a mandible in which all 32 teeth, or on a mandible in which 16 of these 32 teeth are present. It's a bony landmark which is triangular in shape, and it is located behind or distal to the third molar. The triangle has its base here and its apex here. The apex then is the attachment for the pterygomandibular raphe, which will pass in this position. And if you will remember, this area and this raphe is used as a landmark for the approach to the inferior alveolar nerve.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.